So the more fluid gained, the less chances all of it can be removed in one treatment, of course, like I said before. Therefore, patient goes home with some fluid and drinks and eats more on top of it and comes back with more fluid, and the process repeats itself over and over again until they are eventually, hospitalized due to fluid overload. Patients start to swell up and have shortness of breath. And of course, the only way that these patients can work with us is by being educated. They have to constantly be reminded, hey, please watch your fluids. You have to constantly ask them, well, what did you eat, or how much did you drink? To them, they're not eating anything or they're not drinking much, but obviously the weight says otherwise. If they're really not eating or drinking anything, then it's the doctor's job to figure out where is all this fluid coming from. There obviously could be other things that come in play. Whether it's a medication that they're taking might cause them to swell up, and they might not have all that fluid. It's just part of a side effect that this medication has on them. Or maybe there's somewhere else inside the body where fluid is building up, so it's not really the fluid intake, but it might be something else. Observations is definitely one of the major things that we do at our job. For example, if Miss Smith never, she's very compliant. She always comes in and her fluids are balanced out and everything. So, the last 3 treatments she's been gaining a lot. You want to know why. You want to question that, and you want to ask them, well, Miss Smith, what happened? So, and the patients will talk to you. They will tell you, no, I'm not doing anything different. I am not sure what's going on. And this is where, you talk to your nurses, the doctors, if necessary, and they come in play, and, they try to figure out as a team what's really going on with this patient. So there's definitely a lot of things involved in dialysis, depending on how the patient feels, what's going on with their blood pressure, what they're eating, how much they're drinking, how much they're eating. But if they follow their diet, if they follow, through, they should be okay. Maintaining your access, that's another part, a vital part, because without that access, you have no lifeline, meaning you have no way of dialyzing and getting your body back to homeostasis, right? So the access, I always tell my patients, your access is like your little baby. You have to take care of it, baby it to the fullest extent, because that's their lifeline. They must take care of it and follow all the instructions given by the vascular surgeon. Keep up definitely with your vascular appointments. Vascular access should be checked every 3 to 6 months to make sure that it's working properly and that there is no blockage, clots, stenosis, which is a narrowing of the vessel, and that can be seen on the access when there's a narrowing. It's like a flattening of the access, or an aneurysm, which is a bulging of the axis, where the axis is just too huge. It looks like it's about to pop. Or on top of the bulging, there's a shiny spots, where that indicates that axis has that part has a very thin layer of skin, and you cannot use that. So you would have to go on the sides. You would have to insert the needles on the sides of the axis rather than on top of the axis. Aneurysms usually occur when technicians or nurses stick the patients in the same spots. Patients might like it because they're less painful, but I always educate my patients that a different spot every time should definitely be used in order to keep that axis looking beautiful. You don't want an ugly axis, because it does create a problem. You have to buy bigger shirts, or you want to, some people feel embarrassed. They want to cover it. So definitely, maintaining your access is definitely a must. Narrowing of the vessel can occur because the pressure dressings were left on for too long, and it creates a flattening of the access. No heavy lifting on the access arm, no sleeping on the arm. That might be hard, the no sleeping part, but definitely no lifting on the arm. If you or your loved one that's sleeping next to you realizes that you're sleeping on that arm, they should definitely wake you up and say, hey, why don't you turn around? You're sleeping on your arm. They should not leave the pressure dressing overnight, as it might cause clotting of the access or stenosis, most definitely. So there's obviously other things that come in play, like the needle sizes. Like I've spoken before, when the access is brand new, it's a 17 gauge needle, which is the smallest size needle. The bigger the number, the smaller the size of the needle, and the smaller the number, the bigger the size of the needle. The biggest one is 14 gauge. 14 gauge is usually used on bigger people in order to get all that blood processed. 15 gauge is usually the norm for most patients, and that needle is huge. It's really big. 17 gauge needles are used for brand new accesses. Like I said, they do a 1-to-1. They put in that 17 gauge needle and then they put a line to the catheter. Usually the arterial would be the first needle, which is the dirty blood, and then they connect the venous, the clean blood, back to the heart. Once they use that for 2 weeks and it has worked, then they start with the 2 17 gauge needles for another 2 weeks. And after that, they move on to 16 gauge needles for 2 more weeks. And if that works properly, the access has matured enough to use the 15 gauge needles. So once we place those in and all the numbers and everything is fine, now we're good to go. Needle placement is also very important to have adequate dialysis and get the best flow possible. Top needle is your venous line, which is the clean blood, and the bottom needle is the arterial, which is the dirty blood. It sucks it out and puts it back in. Now we'll talk about the dialysis machine, which is a little complicated, but it is actually a very smart computer that will tell you everything you need to know about that patient. It will tell you their blood pressure and pulse on the right-hand side of the machine. It will tell you the venous and arterial pressures of that patient, which lets you know if you're in the right spot, because I always tell my patients that we go in blind-handed. We have no idea. We're only going in based on the feel and the touch of that access. That access has a thrill, so it has a pulsation feeling, so you know where it is. You'll know when it curves, but there are those accesses that are a little bit difficult and they like to hide and play around with you. Rolling veins is another constant issue that we have with some patients, and the list goes on and on. Deep veins, too shallow. So obviously that computer telling you if you did the right job, you feel great about yourself knowing that you have placed those needles in the right place. If there's anything that is wrong, blood pressure is too high, too low, pulse too high, too low, or those numbers are too high or too low, the machine will alarm and you have to come and reset the machine, which means you have to pay attention to your patient. So that is definitely a great help, because we have many patients to take care of, and sometimes it's hard to monitor all of them because you have a problem that just happened with Mr. Smith, and Miss Jacobs is having an episode, so you're taking care of that patient, but you have no clue what's going on with the other one. So that machine alarming definitely helps. Last but not least, dialysis patient, when they're hooked up to that dialysis machine, needles placed and everything, there's a lot that goes in play. They don't always feel well on that machine, as all that blood is being taken out of the body and coming back in. Sometimes they'll feel nauseous, the blood pressure drops, blood pressure is too high, patient is not feeling well, having diarrhea or, excessive vomiting. So there's a lot of other problems that occur because your body needs to get used to this machine. Aside from, you just coming here. The other thing I really wanted to say was these patients come to dialysis 3 times a week for 3 to 4 hours a day per treatment. That's like having a part-time job, because even though your treatment time is 3 to 4 hours, you also have to have a waiting time to get in, an hour here and there, transportation and all that kind of stuff. So it becomes a full day thing. It becomes about 5 to 7 hours for them at times, and it's hard because they can't travel out of the United States. Insurance will not pay for it. They would have to pay out of pocket if they do go on vacation or they do go to their own country outside of the United States. So they are compromised to this little thing. Their life depends on this machine, and they cannot enjoy life anymore the way they used to. So most definitely it is not an easy thing. So in conclusion, dialysis is definitely not an easy disease to deal with. There are a lot of restrictions involved. Therefore, please take care of your health. Take an extra visit to the doctor's office to prevent or to prolong the function of your kidneys. It is very important, just like any other disease, very important. Thank you very much.